Hello everyone and welcome to our module on Starling curves. So shown on this slide is an example of a Frank-Starling curve, a famous curve in cardiac physiology named for the person who first described it. And the Frank-Starling curve shows the relationship between preload to the left ventricle and the stroke volume that the left ventricle produces. And preload, as you may know if you've watched the cardiac physiology video, can be represented by the left ventricular end diastolic pressure or end diastolic volume. These two parameters are proportional to how much volume you load the left ventricle up, and therefore they're proportional to the preload. So what this curve shows is that as you load the left ventricle up with more fluid, in other words, as you move along the x-axis, you achieve a higher stroke volume. And this is because of the Frank-Starling mechanism. That mechanism refers to stretching of left ventricular myocytes. When you add more preload to the left ventricle, you stretch the myocytes and they contract more vigorously, and that generates more stroke volume. And so this positive relationship here between preload and stroke volume is what's shown in a Frank-Starling curve. Now this relationship shown on the Frank-Starling curve between preload and stroke volume is not fixed. In other words, you can have a ventricle operating under the black curve here on the screen, and we'll just call that normal. But then if certain physiologic parameters change, the curve can shift to the left, like the green curve shown here, or to the right, like the yellow curve shown here. So let's talk about some of the things that can shift the curve left or right. So if you have an increase in contractility of the left ventricle, that will shift the curve to the left. It will shift it from the black to the green curve. So let's think about what that means. For a given preload to the left ventricle, if you're operating on the normal curve, you would generate this stroke volume right here. But if contractility goes up, then for that same preload, you now hit this point on the green curve and you're operating at a higher stroke volume. And so hopefully that makes intuitive sense to you. When contractility goes up for a given preload, you're going to generate more stroke volume. And the reverse is true if contractility goes down. If contractility goes down for a given preload, you're going to hit the yellow line and generate less stroke volume. Another parameter that can shift the curve to the left, in other words, shift the curve from the black to the green curve, is the peripheral resistance, which is also the afterload on the left ventricle. If the peripheral resistance falls, then that will shift the curve left, like going from black to green. And so if you think about what that means, for a given preload to the left ventricle, if you have significant peripheral resistance and you're operating on the black curve, you'll generate this stroke volume here. But if for some reason the peripheral resistance falls, there's less afterload on the left ventricle. And now for that same preload, you get up to the green line here and generate more stroke volume. So hopefully that makes intuitive sense to you that when the afterload or the peripheral resistance goes down, for any given preload, you generate more stroke volume. And that's why the curve shifts to the left when peripheral resistance falls. And then if peripheral resistance increases, the opposite happens. You shift to the left curve, and for any given preload, you generate less stroke volume. So I talk about contractility and peripheral resistance in detail in the video on cardiac physiology, but here I've just shown you some of the many things that could change these two parameters. So for example, contractility can increase if there's activation of the sympathetic nervous system. It can increase during exercise or with inotropic drugs. All of these things can cause this leftward shift from black to green shown in the picture. Other things that decrease contractility are things like a myocardial infarction or heart failure. They could shift the curve from the black to the yellow. And then in terms of peripheral resistance, vasopressor drugs increase peripheral resistance, so they will shift the curve from black to yellow like this. And things like vasodilator drugs or distributive or septic shock, these things lower peripheral resistance, and they can shift the curve from the black to the green. So now let's shift gears and talk about a different but related curve to the Frank-Starling curve, and that's the venous return curve, which is shown on this slide here. So the venous return curve shows the relationship between right atrial pressure and venous return to the heart. And in steady state conditions, venous return must equal cardiac output. So that means that this graph is also showing the relationship between right atrial pressure and cardiac output. And so what it's showing is that as right atrial pressure goes up, we get a lower venous return. And let's try to see if we can think through why that is the case. So if we look at this drawing of the heart, right here is the right atrium, and it's receiving blood from the venous system of the body from places like the SVC drawn up here or the IVC down here at the bottom. And the driving force for venous return to come to the right atrium is the difference between the mean pressure in the venous system and the pressure in the right atrium. The difference between these two pressures is the delta P, or the driving force for venous return to flow back to the heart. So anytime the pressure in the right atrium gets lower, there's going to be a greater driving force for blood to go back to the heart, and that's going to raise the venous return. Conversely, anytime the right atrial pressure goes up, there's going to be less driving force and the venous return will fall. So if we go back to this venous return curve, that's what we're seeing right here. As we move along the x-axis, as right atrial pressure rises, we see that the venous return, or the cardiac output, falls. There's this flat portion here, sometimes called the knee of the venous return curve. That's what happens when right atrial pressure gets so low that the veins start to collapse. But anytime you're above that point, you get this relationship here, where higher right atrial pressure means lower venous return or cardiac output. Now, the point at which the venous return curves intersects the x-axis right here is called the mean systemic filling pressure, or MSFP. This represents the right atrial pressure if you had 0 for cardiac output. And so basically, that's the pressure that you would find in the right atrium if there was no blood pumping and the heart had stopped. And we'll talk later about this MSFP. There are certain things that move it in one direction or another. So just like we talked about with the Frank-Starling curve, where the relationship between preload and stroke volume was not fixed and the curve could shift, the same is true for the venous return curve. Venous return curves can also shift left or right if certain physiologic parameters change. So for example, we could move from the black to the green venous return curve if either the blood volume went up or the degree of venous constriction, or the so-called venous tone, increased. So let's see if we can make sense of that. So for a particular right atrial pressure, if we're operating on the black curve, we would generate a venous return or a cardiac output right about here. But if we add volume to the entire venous system, then we're increasing that pressure in the venous system. And remember, it's the difference between that pressure in the venous system and the pressure in the right atrium that is driving the venous return. So if we have more blood volume, this pressure goes up, and therefore this whole driving force for venous return goes up. And so that's why for a given right atrial pressure, when there's more blood volume, you hit a higher value and generate a higher venous return and cardiac output. The same thing happens if you constrict the veins. That increases this pressure right here. It puts pressure on that blood volume in the venous system, and that's going to raise the driving force for venous return and cardiac output. The opposite happens if you lose blood volume or there's venous dilation or a fall in tone. That would shift you from the black curve to the yellow curve here, so that for a given right atrial pressure, you would generate a lower venous return or cardiac output. And so I've highlighted these things in the top right corner. The volume in the venous system and the venous tone are the two parameters physiologically that shift the venous return curve left or right. There's also a physiologic parameter that changes the slope of the venous return curve, and that's the total peripheral resistance. So when there's a fall in total peripheral resistance, that changes the slope of the venous return curve so it becomes steeper, like the way this green curve is steeper than the black one here. On the other hand, if the total peripheral resistance goes up, then you get a flatter or less steep slope like what you see on the yellow line here. And the reason for this is because total peripheral resistance determines how much blood can flow through the body as a whole and make it back to the heart for venous return. So when there's an increase in total peripheral resistance for any given right atrial pressure, you're going to get a lower cardiac output and a lower venous return. And that's because there's more resistance to flow, less blood can move through the body as a whole and be returned to the heart as venous return. The opposite happens if the total peripheral resistance falls. So I've summarized these changes at the bottom. TPR changes can shift the venous return curve right or left, but they don't change the MSFP. This point remains the same, the point that you would get if there were 0 cardiac output in the system. That's not affected by peripheral resistance. So the result is that you get a change only in the slope of the venous return curve when TPR changes. So now that we understand Starling curves and venous return curves, we can talk about combined curves where you put the Starling and venous return curves on top of one another. So when you do this, the cardiac output or the venous return will be on the y-axis. Remember that for Starling curves, the y-axis was the stroke volume, which is proportional to cardiac output. And for venous return curves, the y-axis was cardiac output or venous return. So both of these things are represented by the y-axis on both the Starling and venous return curves. For the x-axis, we talked about how for Starling curves, that was preload. Well, right atrial pressure is one measure of preload. The higher the right atrial pressure, the more preload you're going to have pushing blood into the left ventricle. So this means that we can combine the curves and have the x-axis represent right atrial pressure or preload. And then you get something like this, where this is the Starling curve and this is the venous return curve. And the reason physiologists started overlaying these curves back in the 1960s is because when you do this, the point where they intersect is the point where the system's going to operate. This is going to be the cardiac output of the system as a whole. And what these curves show you is that cardiac output is determined by two things. One is the Starling curve and how much preload there is on the left ventricle. The other is the venous return curve and how much driving force you have for venous return to send blood back to the heart. The combination of those two curves determines this operating point for the system as a whole. So there are some classic combination venous return and Starling curves that you should be able to recognize for your board exams. So let's go through those now. We'll start by talking about heart failure. So heart failure shifts the system from operating on the two black lines shown here to operating on the two red lines. There are three major changes in heart failure. First of all, there's a fall in contractility because the left ventricle is weak. Because the cardiac output's low, the sympathetic nervous system responds and raises the peripheral resistance. And then you also have an increase in fluid volume in patients in heart failure because they are fluid overloaded. So this makes all the changes we see here in going from the black to the red curve. Let's talk about the Starling curve first. We've got a fall in contractility, so that moves us from the black curve to the red curve. And then for the venous return curve, we have an increase in fluid volume, so that shifts us from the black to the red curve. We also have an increase in TPR, so that changes the slope of the venous return curve like you can see here. And if you look at what this is showing you overall, it's telling you that for heart failure, you move from this point to this point. That means that for heart failure, you move from a higher cardiac output on the y-axis, that would be this point right here, to a lower cardiac output. And that's what you expect for heart failure, a lower cardiac output. So these curves, after we make all the adjustments for the physiology parameters, show us what we'd expect to see in heart failure, which is a lower cardiac output. Now let's talk about what happens in hemorrhage. So hemorrhage would shift from the black curve shown here to the red curves. So in hemorrhage, you have blood loss. Blood loss leads to low cardiac output, and this activates the sympathetic nervous system and raises the peripheral resistance. Also, because the sympathetic nervous system is activated, you get a raise in contractility. So let's look at the curves. First of all, because of the increase in contractility, the Starling curve shifts like this. Because of the blood loss, the venous return curve shifts from the black to the red. And then because of the change in TPR, we have a change in slope for the red curve here. And so when you put all these curves together, they tell us that we're going to move from this cardiac output here to this cardiac output here. That means the cardiac output is falling, and that's what we expect in hemorrhage, a fall in cardiac output. So we've used these physiology parameters to show that we get the expected result for hemorrhage, a fall in cardiac output. Shown on this slide are the changes that occur to the curves when a person exercises. So exercise moves you from the black curve shown here to the green curves. So some of the physiology changes associated with exercise include decreased afterload or TPR. There's vasodilation of tissue beds in exercising muscles, and that lowers the TPR. There's also venous contraction because the sympathetic nervous system gets activated by the lower TPR and it constricts veins. And then the sympathetic nervous system also increases contractility on the heart. So if we look over here at the curves, the increase in contractility would shift the Starling curve like this. The venous contraction will shift the venous return curve like this. And then you've got a change in TPR, which is modifying the slope of the venous return curve. And so the net result of all these changes are that you go from this cardiac output down here to a much higher cardiac output over here. And that's what you expect with exercise. With exercise, the cardiac output goes up because the heart's contracting more vigorously and the heart rate goes up, and there's more preload from venous contraction. Shown on this slide are the changes in the Starling and venous return curves in a person with an AV fistula, and they're identical to the changes you get with exercise. So to understand this, let's talk a little bit more about AV fistulas. So we have blood that's in the arterial system in the body, and then we have blood that's in the venous system in the body. And the only way for blood to get from the arterial system to the venous system is for blood to pass through the arterioles, which are resistance vessels that supply a lot of resistance to flow. They're the major determinants of our total peripheral resistance. Well, if there's an AV fistula, then there's some other connection where blood can bypass the arterioles and get into the venous side. This makes it much easier for blood to flow from the arterial venous side. In other words, it lowers the resistance because blood is bypassing those high resistance arterioles. So anytime you create an AV fistula in the body, the major physiologic change is a fall in the afterload or the TPR. Now, because the TPR falls, this triggers the sympathetic nervous system and there's increased contractility. Also, because of the sympathetic nervous system being activated, there's venous contraction. And so all those changes get you the change in the curves shown here, going from black in this cardiac output to green in this higher cardiac output. This is what you expect with an AV fistula, a higher cardiac output. And then finally, shown on this slide are the changes that occur in the curves when a patient is administered a vasopressor drug. Vasopressors cause the curves to shift from what's shown in black here to what's shown in green. So what vasopressor drugs do is they cause vasoconstriction, usually of arterioles, and that increases the afterload and raises the TPR. When the TPR goes up, the blood pressure goes up and sympathetic nervous system activity decreases. So there's going to be a fall in contractility associated with a rise in TPR. Also, because there's less sympathetic nervous system activity, there's a fall in venous tone. Remember, the sympathetic nervous system can constrict your veins to push blood back to the heart and raise the preload, but when there's less sympathetic nervous system activity, the veins dilate and pool blood and lower the preload. So if you look at these curves on the screen, all these changes are depicted here. The fall in contractility and TPR shifts the Starling curve like this. The change in venous tone shifts the venous return curve like this. And then because peripheral resistance changes, you get a change in the slope of the venous return curve. And the net result is that you go from this point here, associated with a higher cardiac output, to this point here, associated with a lower cardiac output. And hopefully that makes sense to you. Vasopressors increase the afterload on the left ventricle. They raise the TPR, and this is going to decrease the cardiac output. That's what you expect to have happen when you administer vasopressors. And then I'll finish this video with this slide talking about how you can answer questions that ask you to find actual numbers for the cardiac output based on the Starling and venous return combined curves. So you could be shown a graph like what's on the screen here on your board exams. It's got 3 Starling curves here and 3 venous return curves. And they could ask you for a patient on Starling curve A right here with an MSFP of 10, what is the cardiac output? So they're telling you that the patient is operating on the green venous return curve, curve A. And then they tell you that the MSFP is 10, so this person must be operating on the yellow venous return curve shown right here, because that's the only one with an MSFP of 10. Well, if we look at where the green Starling curve and the yellow venous return curve intersect, that's right here. So that would be associated with a cardiac output a little less than 5, probably around 4 or so. So be aware that on your board exams, you may see questions like this where you're given specific numbers along the x-axis and the y-axis, and you're asked to determine the cardiac output. It's simply a matter of picking the numbers off the graph. And that concludes our module on Starling curves.